Introduction to Caregiving, Module 1. What is caregiving? Until about 20 years ago, the word caregiving was not something that you heard on a regular basis in the English language. It still is not even recognized as a word. If you type the word caregiving, C-A-R-E-G-I-V-I-N-G, you'll get the little red line underneath it on your spell check indicating that it's not a word. It has been adopted because it's been used so much in the last several years, but again, it was a concept that's relatively new. Former First Lady Rosalynn Carter has a quote that is used extensively. She says there are 4 kinds of people in the world: those who have been caregivers, those who currently are caregivers, those who will be caregivers, and those who will need caregivers. Well, what does that mean? It means that everyone, regardless of their age, gender, race, socioeconomic status, at some point in their life will be a caregiver. If you look up caregiving in the dictionary, you'll get a definition somewhat like this: the act of providing assistance and support to individuals who have physical, psychological, or developmental needs. So let's spend a few minutes talking about who needs caring. All of us need caring and personal attention from others at certain times during our lives. Understanding, support, compassion, and comforting are particularly important to those individuals who have acute or chronic illnesses, or who are disabled and limited in their functional effectiveness. As we examine the various issues involved in caring, it's necessary to consider the range of individuals who need caring and the diversity of their situations. Let's talk first about those with acute health problems and illnesses. All newborn babies, because of their vulnerability, have special needs for nurturing and bonding, whether in the hospital or at home. But premature babies, those who are at risk of medical problems and of very low birth weight, need caring especially. This is a population that has really increased over the last 2 decades. Premature infants may spend weeks or months in an acute hospital setting prior to being released into the care of their mother. So they'll be receiving care from both professional caregivers in the hospital and then from parents once they return home. And they may have a lot of special needs. Mothers of these premature babies will need continuing support, information, guidance, attention, and caring from their baby's physicians and nurses, even after taking the baby home. The most frequent acute illnesses experienced by children are infectious diseases. Most of these are relatively benign and don't require medical care from a physician or nurse. But sometimes the common infections of childhood and adolescence are severe, such as those who have asthma or serious chronic diseases such as cystic fibrosis or congenital deformities. Injuries such as fractures, sprains, open wounds, and lacerations and concussions are the most important sources of acute health problems in infants, children, and teenagers. I think all of us can remember sustaining some of these injuries ourselves when we were young. And while most of these can be cared for relatively easily, some of these children need considerable assistance, attention, and support until fully recovered. Child abuse is a major national problem that creates acute and chronic care needs. Of most reported cases of child abuse, the majority involve physical abuse, and second behind that is sexual abuse. Abused children, especially those who are victims of sexual abuse, can experience acute problems that might produce long-lasting harm as well. Emerging standards of care for abused children recognize that patience, compassion, and support from healthcare providers and from family, relatives, and friends are essential. Substance abuse also creates a need for care. The abuse of alcohol, hallucinogens, cocaine, heroin, and other drugs alters behavior of abusers and has a very negative impact on family. And although stroke is a cause of chronic disability, its onset is usually acute. Immediately following an acute episode, affected persons can be frightened and need comfort, companionship, and support, usually by family members in their home. Although the need for caring can occur throughout the life course and in a variety of settings, Caring is needed over extended periods of time, usually years, for persons of any age who have serious chronic illnesses and disabilities, because they require continuous support in carrying out functions that are essential to daily life. In the past 30 years, the proportion of chronically ill and disabled people residing in institutions has declined steadily, because most of them now live at home with families or in community residential settings. Their need for caring and support from a spouse, child, other family members, and friends is especially important. In the absence of or in combination with support from these sources, people may choose to or need to rely upon formal paid services. But even with this formal assistance, there may be a lack of support and caring, and the consequences can be very negative. The extent of need for caring can probably be best understood in terms of the level of activity at which persons with chronic illnesses and disabilities can function in their daily life. Although it's clear that many people in the United States report some type of chronic condition, fewer than half of them are limited in their daily lives by these conditions. Among those that are limited, fewer still are unable to carry out their major activities, such as going to school or work. A growing number of people are having difficulty performing one or more activities of daily living: bathing, dressing, getting out of a chair or bed, toileting, or feeding themselves. About half of these require the assistance of another person to perform these core daily activities. Needs for assistance stem from the inability to perform instrumental activities of daily living, such as managing finances, telephoning, shopping, preparing meals, and being able to go outside the home independently. Disability is defined by limitations that hinder performance, entailing a loss of independence. Therein lies the paradox. Disabled persons require assistance with the most intimate aspects of daily life so that they can sustain and enhance their independence with respect to other aspects of living. But such assistance can further dependence rather than foster independence, depending on how it is organized and provided. You should be familiar with the 12 most common conditions causing activity limitation. And we'll start with number 1, heart disease. Number 2, deformities. Number 3, osteoarthritis. Number 4, orthopedic impairments. Number 5, asthma. And number 6, diabetes. While the prevalence of heart disease and stroke has remained essentially the same over the past 10 years, the prevalence of hypertension, high blood pressure, has shown a general increase in the last 10 years. The most recent data on obesity in the United States is that 1/3 of all adults are obese, and approximately 17% of children and adolescents are considered obese. This has created a drastic rise in the number of cases of diabetes in the United States. A whopping 8.3% of the population have diabetes, which is 25.8 million children and adults living in the United States. Complications from this increase in diabetes is an increase in heart disease and stroke. Adults with diabetes have heart disease death rates 2 to 4 times higher than those without diabetes, and the risk for stroke is 2 to 4 times higher among people with diabetes. You may not know that diabetes is also the leading cause of new cases of blindness among adults aged 20 to 74. It's also the leading cause of kidney failure. 60 to 70% of people with diabetes also have mild to severe forms of nervous system damage, and more than 60% of non-traumatic lower limb amputations occur in people with diabetes. The cost of diabetes has skyrocketed in the United States to $174 billion a year. That's the total cost of diagnosed diabetes in the United States. $116 billion for direct medical costs and $58 billion for indirect costs, such as disability, work loss, and premature death. To continue on with our list of chronic illnesses and disabilities, number 7, mental illness. 8, disorders of the eye. 9, learning disability and mental retardation. 10, cancer. 11 visual and hearing impairments, and 12 cerebrovascular disease. Let's talk for a minute about the rise of cancer, which has definitely created a need for more caregivers. About 1,596,670 new cancer cases will be diagnosed this year. More than 571,950 Americans will die of cancer. More than 1,500 people a day. Cancer is the second most common cause of death in the United States, exceeded only by heart disease. In the United States, cancer accounts for 1 out of every 4 deaths. And in a category all on its own, at the top of the list for chronic illnesses, for older adults especially, is Alzheimer's disease and other forms of dementia. 1 in 8 older Americans, or 5.4 million people in the United States, have Alzheimer's disease. There's a new diagnosis every 72 seconds. There are 14.9 million unpaid family caregivers caring for these people, and it's costing our economy $183 billion annually. Before concluding our discussion of who needs caring, it's important to consider the factors that affect access for the acutely ill, the chronically ill, and the disabled to the compassion, understanding, and support that caring comprises. First of all, let's talk about family circumstances. The family remains the most prominent resource available to most people who need caring. This seems to be true in terms of illness and disability across age groups and in the amount and quality of care. However, the extent to which families are able and willing to provide caring does vary in relation to various groups that need supportive care. It's no surprise that parents are the primary sources of care for children. However, working age adults with physical disabilities, developmental disabilities, or chronic mental health problems are in more uncertain territory with respect to family care. Most adults with disabilities want to be independent, productive, and self-sufficient. But over time, many have become dependent upon their family resources to supplement what are frequently inadequate public benefits, including income assistance, medical assistance, housing, and transportation. On average, dependence on family care may be lowest among those with physical disabilities and highest among those with severe mental illness. Older people with physical and cognitive or mental disabilities usually depend on caring family members, especially spouses and children. But society's expectations concerning these family obligations have been changing. While society values a commitment to care, adult children who might undertake caring are also encouraged to pursue job opportunities, to raise and nurture their children, plan for their future relatively free of obligations to an earlier generation. These competing commitments, along with the extent of family financial resources and the physical and psychological capacity to care for others, will continue to change over time, and not necessarily in positive ways. Single parents. Today there are about 14 million single parents in the United States. They are responsible for raising 21.6 million of our nation's children. The statistics show that 80% of single mothers are employed and 90% of single fathers are employed. When a child is acutely ill, their parent is faced with the dilemma of either leaving work to care for them or remaining at work. In the latter case, either the child is neglected or the working parent must depend on others and often be unsure about the quality of care that their child is receiving. This dilemma has spread to more families as national and state efforts to reduce welfare rolls led to greater numbers of poor single parents to become employed. Moving to a new location creates additional problems as well. A move to a distant location makes it hard to identify people who could and would provide support in caring for the children. It also results in separation of parents and children from grandparents, other relatives, and friends who could assist in the caregiving role. Leaving the family. As children mature into young adults, they leave home and often lack the immediate supportive environment of families and friends. For young persons with severe disabilities, this can be a particularly stressful transition, especially when they go away to colleges and universities. The physical environments of these educational institutions have been increasingly modified in recent years to provide better movement around campus for physically disabled students. But the support, compassionate treatment, and concern they may require might be lacking, both from the institutions who are required under the Americans with Disabilities Act to provide supportive services and from their fellow students. Able-bodied students may find it difficult to associate with seriously disabled students. However, it is impressive how many students on a college or university campus are sensitive to the supportive and compassionate needs of disabled students and provide a measure of care for them. For these students to become involved with seriously disabled classmates, the experience can be important to their subsequent lifelong understanding and support for persons with disabilities. The family and caring for older persons. Older persons who have never married have no spouse and may also have no children available to undertake caring. Also, it's become quite common for people like myself to be married and have no children. So there is no built-in child to afford my care when I need it. Among married couples, older women, especially those 75 and older, are less likely than older men to have a caring spouse. For every 9 women in this age range, there are only 5 men. So older women are more likely to be living alone and may be too poor to afford paid services for their care. Today's extended life expectancy has resulted in increasing numbers of 4-generation families. It's becoming common for very old and impaired parents to look for caring and support from their elderly children. However, when elderly children are also impaired, the challenges of caring for 1 or 2 parents may be too much for them. In such cases, children in the 3rd generation of the family may find the problems of caring both for parents and grandparents to be overwhelming. Younger adult children also confront substantial difficulties in being able to provide caring for a parent at the level to which they wish they could. Middle-aged women in particular confront the multiple challenges of maintaining their jobs, caring for their children, and in some circumstances, an ill spouse, and caring for their parents and parents-in-law. We call this sandwich caregiving, with that woman being squarely in the middle, caregiving on both ends of the spectrum. Substantial geographic distance from the parents can also inhibit the caring capacities of children. Social circumstances. Even when family members and neighbors are nearby, one can be alone. Not all families and neighbors are willing or prepared to provide the support, understanding, and compassion that people with care needs might require. The affected person might be isolated and alone at home, with family or friends nearby. Under these circumstances, some older persons and children may be neglected and even abused. Sick and disabled persons who are alone or isolated from friends and family in large inner cities can also have a very difficult time when in need of support and caring. In recent years, there's been a large growth in the number of inner city men and women who are poor, substance abusers, or have AIDS. Although these people dwelling in single-room occupancy establishments or homeless live in the midst of a lot of people in areas where medical facilities are available and many social service programs operate, society too often seems to ignore their presence and their needs. For a variety of reasons, family may not feel responsible for members who are in desperate need, or if they feel responsible, their own life circumstances might keep them from being as supportive and caring as they wish to be. Even neighbors living nearby may neglect the presence of one who is in need of support and compassion. In rural areas, people typically know each other, work together, go to the same church, and are familiar with each other's successes, failures, and problems. In many of these communities, people tend to look out for one another, but not always. The circumstances of modern health care. Enormous advances in medical science and technology have improved medicine's ability to alleviate and cure disease, both acute and chronic. But listening, compassion, and support for the patient and family have almost become a thing of the past in physicians' offices, clinics, and hospitals. Changes in the financing, organization, and delivery of medical care, and the modern array of diagnostic and therapeutic technologies have had major effects on the opportunity and time available for physicians to provide the support, compassion, and understanding that most patients need and would like to receive. Many physicians want to provide compassionate care for their patients, but they just don't have the time. Recent statistics show that the average length of a visit with your doctor is 7 minutes. Patients are released from hospitals quicker and sicker, and the family caregiver is expected to do things that only licensed clinical social workers and nurses were allowed to do just a few years ago. Caring by professionals and agencies, special issues for disabled people. In any given year, the vast majority of people in the United States have some contact with the medical care system. Whether it's a routine examination, some tests, or minor surgery, medical interaction is a risky business, and most of us have experienced the sense of dependency and uncertainty associated with being in the patient role. For persons with disabilities, not only is the sense of vulnerability experienced in medical encounters amplified, but it also extends to other helping relationships, to all aspects of living in which they seek to feel secure, enhance their autonomy, and gain a sense of personal fulfillment. We'll go into much more detail about these special issues further into the semester. Finally, economic circumstances can also limit access to caring. There's been a record rise in the number of people without health insurance in the United States. A recent statistic is 50.7 million people lack insurance in the United States. If these people do seek health care and are unable to pay for it, an emergency room will probably be where they receive the care. In this setting, healthcare professionals are rushed and have little time for compassion, even if they wanted to express it. Those who use emergency rooms for their care are not able to establish an ongoing, continuous relationship with a doctor, and this inhibits an essential ingredient of caring, some knowledge of the patient as a total person. Even in middle-class families, economic factors can limit the quantity and quality of caring. Employment obligations often make direct caring by family members difficult or impossible. Many employers do grant leaves of absence that can last several months for new mothers, and for more limited periods for employees with relatively short-term caring responsibilities. But middle-class family members who have long-term caring responsibilities must rely on hiring people to fill the gaps, and frequently they find that the cost of this support is something they just can't afford. The economics of America's healthcare system also tend to limit caring. The contemporary emphasis on economic accountability in both the free market and public sectors generates pressures that reduce opportunities for caring. Financing and organization of healthcare leaves physicians and other healthcare professionals with little time and latitude for undertaking the levels of compassion, understanding, and support that most of them would like to provide for their patients. I want to talk now about the basic elements of caring. Knowledge is the first. What do we mean by knowledge? This means understanding the care receiver's needs, their powers, and their limitations. Having knowledge about the illness or the disability for which you're caring for. Knowledge is key. Another element of caring is patience. Letting the person you're caring for grow in their own time. Patience to allow them the independence and autonomy to do as much as they possibly can for themselves for as long as they can possibly do it. Honesty. Honesty means being genuine. Seeing the person that you're caring for as they really are, not how you would like them to be. Being honest in your feelings towards providing care and towards the person you're providing care for. Trust. trusting your capacity to care, and also allowing the care receiver freedom to make choices and mistakes. Again, this goes back to autonomy, not overprotecting, trusting that they will do what they can do to the best of their ability. Don't take that away from them before it's necessary. Humility is another element of caring. You need to always be ready and willing to learn more about the person that you're caring for. Hope. Hope is appreciation of the present as alive with possibilities for the future. Hope does not mean believing in miracles. It means being realistic, but having hope that there will be good times and bad times throughout the course of caregiving. Courage. Courage means taking risk, moving into the future with confidence and the insight gained from your past and present experiences as a caregiver. The best way to summarize these elements of caring is the old golden rule that we were all taught as a child. Do unto others as you would have them do unto you. We've talked a lot about caregiving in this session, from the definition of care to talking about the different populations of individuals who need care. So I want to end up talking about what are the benefits of caregiving for the person that's receiving the care. First is the maximization of functioning. If a person with care needs is being provided good, compassionate care, they will be able to function at a higher level for a longer period of time. Another benefit is the prevention of dependency and the pursuit of autonomy. I've already talked about this some. Most people want to do as much for themselves as they possibly can for as long as they can possibly do it. This is easier to accomplish if you're being cared for. Another benefit of caregiving is the relief of pain and suffering. When you have someone tending to your needs, making sure that you get to your doctor's appointments, making sure that you get your medications on time and in the right amounts, this can help relieve pain and suffering. Physical and psychological security. A person with a chronic illness or disability or other care need can feel much safer and secure physically and emotionally when they have someone that they love and that they care about and that they trust caring for them and looking out for their best interests. And last but certainly not least, realizing psychological and spiritual needs. The good caregiver, the best caregiver, will realize that this is a very important part of giving care. It's not just about the physical part, the bathing, the tending to wounds, the feeding, and all of that. It's also realizing that this person has some psychological and spiritual needs. And if you can't meet them yourself, you can ensure that the person you're caring for has access to the people or services that can help them fulfill their psychological and spiritual needs. Make sure that you have completed the assigned reading and the 8 assigned video clips for this first module, What is Caregiving? And I look forward to seeing you for Module 2, Who Provides Care? Thank you.